cataract surgery in nanophthalmic eyes. And I think we're moving from a very broad spectrum. You moved us, Ashraf, from multifocal premium surgery to this procedure. Through the video, you will see how straightforward it would look to the viewers. But allow me to comment through the video on how we faced obstacles until we came out with the best outcome. So I had 3 siblings, 6 eyes, with a nanophthalmos eye. The axial length was 13 in all of them. So you can imagine you could just poke the eye with a very trivial punch. The corneal diameter was 9 millimeter, as you can see, and the intraocular lens power was 62 in one eye and 60 in the other eye. We discussed with the patient the refractive outcome because IOL power calculation is never predictable. We also discussed the risks because this is a very small eye. As you can see, I poke the eye in order to be able to reach it. My tip of finger is larger than the globe, if you can see. And we proceeded with the phaco. The patient took mannitol and Diamox before surgery in order to decrease the pressure coming from the vitreous. And then we proceeded with the surgery. I'm not going to say a lot. I just want a video, although we were on our nerves during the procedure. I tend to do my rexes on the small something happens, I always use the anterior capsule, which is sufficient enough. So this is a small rexus that I used to perform. And because he's young, aspiration was just so easy. His vision was counting finger 3 meters, by the way. So I just aspirated the lens. And this was the first eye of the 6 eyes I've done. And I learned something before. So in the next eyes, not to remove my 2 instruments or 2 hands from the AC and allow it so quickly like this. So this is something I wouldn't do again. Inject a lot of viscoelastic before you draw your second instrument or your second piece of instrument you're using inside the eye. So yeah, I'm doing this again, but I was saved by a lot of prayers. I was quick, so not to allow any complications to happen. And there's a very big list of complications that would happen with these patients. Please ask me about it when we finish, Ashraf. So this is the lens. It's a very customizable lens. It's a CT Extreme D from Carl Zeiss. And it's a very thick lens. You can see me struggling in tucking it in the injector. And I want to show you without editing how we struggled to tuck it in. And you see 3 loops, and it's not a multifocal lens, it's only a monofocal lens, but because it has a very high power, it is incremented in 3 loops. And it's only a 6 millimeter in diameter. You can see it's half almost half the normal IOL, or the usual IOL. And one trick, inject it slowly outside a little bit because it's very thick. It gets stuck in the injector. So you have to use a lot of viscoelastic and try it fully because the rate of posterior capsular rupture is high in these patients. I inject half of it in the bag, and the other half I tuck it in with my Sinski hook. It's a thick, small lens. And voila. This is an uncomplicated surgery with lots of preparation, lots of prayers, lots of struggling, lots of patient counseling, and lots of things to learn about how close to being complicated these eyes are. And thank you.
Thank you so much, Nancy. This is a very interesting case, but I have a lot of questions, really. This type of lens, what is the size of your anterior rexus you are going to do?
The size of the rexus is 5 to 5.5 millimeter. The eye is small. The cornea diameter is 9, so tend to do a smaller rexus than usual for many reasons. The first thing is that you don't have to, it's still in front of your eye. It doesn't tear out whatsoever, especially that these are young patients. The second thing is that the lens is a small lens, and so you capture it with having the size of the rexus covering it all over. And even if you have like a posterior push from the vitreous, having a small rexus with the lens, even if you put a heel on a heavy heel on or an OVD inside, you can push the vitreous in a good way during the surgery.
Another question: why you choose this procedure? Why you didn't do a piggyback IOL? Because if you post-operative, if you have a refractive surprise, you can remove the second IOL and you can change it, because this is one IOL. Also, why you didn't do a posterior rexus with anterior vitrectomy, and you did a capture of the first lens away in the like a posterior capture?
Okay, so I'll start from the last question. Now, these patients are at a very high risk of having malignant glaucoma. So one of the recommendations is to do a limited anterior posterior vitrectomy. The instruments were not available at the time, and I felt safe giving mannitol and Diamox before surgery. So I was playing it safe, although I had that in mind in subsequent procedure, but I never had to use it on all the 6 eyes. This is one thing. The other thing, but if you're happy, the second thing is piggybacking. This eye is very small, that the axial length is 13, and the AC depth is 2.2. There's no way I could piggyback, put a lens or and add a lens afterwards. I would do this in eyes with 35, 36 diopter IOLs with an axial length of 18, 20. I would think of this. And we had a patient like a few days ago who had a 40 diopter IOL. We inserted the 35 diopter lens and left the rest to do something about it when she comes next week for a refraction. We either do a LASIK surface ablation to accommodate the residual error, or a piggyback IOL. But an eye like this with a 13 millimeter all in all, I wouldn't think, except of the CT Extreme from Zeiss.
And which formula you used when you choose the IOL power in these very small eyes?
Yeah, IOL formulas are very unpredictable in nanophthalmic eyes. They're not only microphthalmic, they are nanophthalmic. And you have to be able to discuss with the patient that there would be a possibility of a refractive outcome, a surprise or a problem. So what I prefer to do is take more than one formula, more than one measurement, and compare them. Now, the best till now is the Barrett 2 universal formula that gives you the best predictive outcome with a very low margin of error of 0.2, only 0.2 margin of error. The other formulas, which is the best in a row, comes the Hagees formula and the Hofer-Q, but they give you a wide margin of error, actually up to 0.6. So, but all in all, never use the traditional SRK2 or SRKT. They do the worst in these very short eyes.